Jaundice is the most common condition that requires medical attention and hospital readmission in newborns. Neonatal jaundice may have first been described in a Chinese textbook 1,000 years ago. Medical theses, essays, and textbooks from the 18th and 19th centuries contain discussions about the causes and treatment of neonatal jaundice. In 1875, Orth first described yellow staining of the brain, in a pattern later referred to by Schmoll as kernicterus. 1 gram of hemoglobin produces 35 mg of bilirubin. Compared with adults, newborns have a 2-fold to 3-fold greater rate of bilirubin production, 6 to 10 mg per kg per 24 hours versus 3 mg per kg per 24 hours. 1 gram of albumin binds 8.5 mg of bilirubin in a newborn. Define jaundice. Jaundice is a visible manifestation in skin and sclera of elevated serum bilirubin. Risk factors. Jaundice within first 24 hours of life. A sibling who was jaundiced as neonate. Unrecognized hemolysis. Non-optimal sucking, nursing. Deficiency of G6PD. Eye infection. C. Cephalometom/bruising. E. East Asian, North Indian, etiology of unconjugated hyperbilirubinemia, if hemolysis present. Common causes are blood group incompatibility, ABO, Rh, Kell, Duffy, infection. Rare causes: red blood cell enzyme defects, glucose 6-phosphate dehydrogenase, pyruvate kinase. Red blood cell membrane disorders, spherocytosis, ovulocytosis, hemoglobinopathy, thalassemia. If hemolysis absent. Common causes: physiologic jaundice, breast milk jaundice, internal hemorrhage, polycythemia, infant of diabetic mother. Rare causes: mutations of glucuronyltransferase enzyme, Crigler-Najjar syndrome, Gilbert disease, hypothyroidism. Pathophysiology. Neonatal physiologic jaundice results from simultaneous occurrence of the following two phenomena: shortened lifespan of fetal erythrocytes and the higher erythrocyte mass in neonates. Leads to increased breakdown of fetal erythrocytes. This leads to increased bilirubin production. Low concentrations of the binding protein ligandin in the hepatocytes and low activity of enzyme glucuronyltransferase. Leads to decreased hepatic excretory capacity. Types of jaundice: physiological jaundice, pathological jaundice, breast milk jaundice, breastfeeding jaundice. Physiologic jaundice. Characteristics of physiologic jaundice. Appears after 24 hours. Maximum intensity by 4th to 5th day in term and 7th day in preterm. Serum level less than 15 mg per dl. Clinically not detectable after 14 days. Disappears without any treatment. Pathological jaundice. Characteristics of pathological jaundice. Appears within 24 hours of age. Increase of bilirubin greater than 5 mg, dl, des. Serum bilirubin greater than 15 mg, dl. Direct bilirubin 2 mg, dl. Jaundice persisting after 14 days. Stool clay, white-colored and urine staining clothes yellow. Breast milk jaundice may be associated with unconjugated hyperbilirubinemia without evidence of hemolysis during the first to second week of life. Breast milk may contain an inhibitor of bilirubin conjugation or may increase the intrahepatic recirculation of bilirubin because of breast milk glucuronidase. Bilirubin levels rarely increase to greater than 20 mg per dl. Interruption of breastfeeding for 1 to 2 days results in a rapid decline of bilirubin levels, which do not increase significantly after breastfeeding resumes. Breastfeeding jaundice. It begins 2 to 4 days after delivery and mainly due to inadequacy of breastfeeding results in decreased caloric and fluid intake leads to decreased hepatic clearance. Kramer's rule describes the relationship between serum bilirubin levels and the progression of skin discoloration. Level 1. If the jaundice visually seen in the head and neck, the bilirubin level will be 4 to 8 mg per deciliter. Level 2. If the jaundice visually seen in the upper trunk, above umbilicus, the bilirubin level will be 5 to 12 mg per deciliter. Level 3. If the jaundice visually seen in the lower trunk on thighs, the bilirubin level will be 8 to 16 mg per deciliter. Level 4. If the jaundice visually seen in the arms and lower leg, the bilirubin level will be 11 to 18 mg per deciliter. Level 5. If the jaundice visually seen in the palms and soles, the bilirubin level will be more than 18 mg per deciliter. Investigations. Blood type and Rh determination in mother and infant. Direct antiglobulin test, DAT, in the infant, direct Coombs test. Hemoglobin and hematocrit values. Serum albumin levels. Measurement of end-tidal carbon monoxide in breath. Peripheral blood film for erythrocyte morphology. Reticulocyte count. Conjugated bilirubin levels. Liver function tests. Tests for viral and/or parasitic infection. Reducing substance in urine. Blood gas measurements. Bilirubin binding tests. Thyroid function tests. Ultrasonography of the liver and bile ducts. A radionuclide liver scan for uptake of hepatoaminodeacetic acid, HEDA. Purpose of management is to reduce level of serum bilirubin and prevent bilirubin toxicity, prevention of hyperbilirubinemia by early feeds, adequate hydration, reduction of bilirubin levels, phototherapy, exchange transfusion. Continued and frequent breastfeeding and correction of dehydration helps. More effective intestinal motility. Decreased intrahepatic circulation. Enhanced removal of photoproducts in both urine and stools. Phototherapy is a simple, effective, inexpensive and acceptable procedure for the reduction of bilirubin molecules in the peripheral tissues into biliverdin by the absorption of light photon. Exchange removes partially hemolysed and antibody-coated RBCs as well as unattached antibodies and replaces them with donor RBCs lacking in sensitizing antigen. Blood for exchange. For Rh hemolytic disease or Rh negative blood. For ABO incompatibility or Rh negative or Rh compatible with baby. Drugs to increase bilirubin conjugation. Phenobarbital 5 to 8 mg per kg every 24 hours. Inhibition of reabsorption. Oral agar 500 mg per kg every 6 hours. Inhibition of bilirubin production. Metalloproporphyrins, tin and zinc, inhibition of hemolysis. High-dose intravenous immunoglobulin, 500 to 700 mg per kg IV over 2 to 4 hours.